patient on ventilator. So in previous days, whenever a baby was ventilated, we used to monitor him on based on our clinical examination. We used to check for the adequacy of settings based on the clinical examination. Then came time for X-rays, which further fine-tuned our management because putting a patient on ventilator is easy, but knowing whether our
Dr.
settings are
Akash, can you just increase your volume a bit? You're audible, but voice is a little bit on the lower side. So can you just increase the voice a little bit?
hello, it's fine now.
It is audible, but still, can you increase a little bit more?
Hello.
Yes, yes.
So then came the time of blood gases. Both X-rays and blood gases, although they are very important for fine-tuning the ventilation, but both of these are time events. That is, they do not give a real-time picture of what is going on, whether our settings are adequate or not. And so then came the modern era where flow sensors became more refined. They became more small, more lightweight, so that they had uh, less dead space. And now this flow sensor, what is shown in the picture right in front of your screens, is now the heart of the modern ventilation. And it is because of this flow sensor that it has been possible to have graphic display in modern ventilators, which gives us a real-time picture to know about the disease process, to know about the patient ventilation interaction, and to fine tune our and finally know about the complications like air leaks and air trap. So graphics, they give us a complete information about what treatment we are giving, whether it is adequate or not. It also tells us about the pathophysiology of the lung. For example, in the RDS, it tells us about the lung compliance, whether it has improved, decreased. It also helps us to know what the patient is, how much tidal volume the patient is generating, and that can help us in the weaning process. And as we discussed earlier, it also tells us about the various myths and adventures which are associated, which can be associated with ventilation. For example, air trapping, tube leakage, and others. Now, broadly classified graphics are of basically two types. One is the scalars and other is the loops. Scalars are the one where the variables are plotted against the time. That's why they are called as scalars. And the other hand, we have the loops, which where two variables are plotted against each other. In scalars, we have a pressure scalar, flow scalar, and volume scalar. As the name itself suggests, the variables are plotted on the y-axis and the time is plotted on the x-axis. And we'll be discussing one by one, and we'll be discussing about their utilities, where they can be used, and how we can fine tune our ventilation. Now, coming to the first curve, that is the pressure curve. As you can see in the diagram, whenever the expiratory valve closes, as as you can see with the help of the cursor on the screen, whenever the expiratory valve closes, the pressure suddenly increases above the PEEP to the PIP which we have set. And once it has reached the desired PIP, it stays there. That is, the plateau is reached till the TI is complete, whatever TI we have set. And finally, the expiratory valve opens and the pressure drops back to PEEP, and this completes one respiratory cycle. Usually, this curve is important to know about the flow, whether the flow is adequate or inadequate. Usually, the plateau should be reached within one third of the inspiratory cycle. So, from this point to this point is the TI. So, this peak should be reached usually within the first one third of the TI. If it is now, subsequently in this picture, you can see we discussed that the plateau should be reached within the first one third of the TI. Here, the PIP is reached at the end of the inspiration. This is because of the inadequate flow. You can also see that the plateau is narrowed down. This is because of the short TI. So when we increase the TI, it becomes normal. Similarly, on the other hand, if we have a short TI, then this slope becomes almost a straight line and the alveoli are rapidly opened up, which are damaging to the lungs. Coming to the second curve, which is the flow curve. So we can see as the flow increases to reach the peak inspiratory flow, And then once the pressures are equal between the circuit and the alveoli, there is a phase of zero flow. And then the expiratory valve opens, the pressure, the flow moves away from the patient, and then finally this is the expiration is completed. So between this point to this point we have Ti, and between this point to this time this is expiratory time. This flow curve helps us to adjust between Ti and Te. Now if before the completion of inspiration the expiration starts, that means there is an inadequate Ti. That's why the inspiration has not completed but expiration is already started. Once we increase the Ti, we get a normal graph. Similarly, if the TE is very short, then before the end of the expiration, the inspiration starts. And once we increase the TE, the graph becomes normal. So this scalar helps us to determine the adequacy of Ti and Te. Similarly, we can also, with this graph, we can also detect to see whether the Ti is prolonged or not. So as we said that once the pressures between the circuit and the alveoli are equilibrated, that is they become equal, it's called as zero flow. So there is a zone of zero flow. And as you can see, although the pressures are already reached, but because we have set a long Ti, the patient has to spend this much extra time with those high pressures because of the long Ti. So this is because of the long Ti, and once we adjust the Ti, it becomes again a normal. So this phase of zero flow should be as small as possible. Otherwise, patient is uh, exposed to high pressures which are not required because the PIP is already reached. Coming to the third scalar, which is the volume curve, it tells us about the leak, which is not possible with the flow curve or the pressure curve unless and until the leaks are very large. Here, the patient had a small ET tube and there was a peritubal leak, and we can see that the volume has not reached the baseline. This is because of the leak, and this can be easily detected with the help of this volume curve. Coming to the loops, where two variables are plotted against each other, we basically have two types of loops. One is the PV loop and other is the uh, flow volume loop. Coming to the PV loop, this is one of the most important graphics. Here we can see this is PEEP. This is the inspiration and this is the expiration. As you can see, we have two separate lines for the inspiration and expiration, and usually the expiration is more wider than the inspiration. This is because of the trapping, because the volume during expiration is more compared to inspiration. This is because of the trapping of the gas in the small alveoli. The midline of this curve is called as the compliance curve because the slope of this curve tells us about the compliance of the lung. So normally the slope forms a 45-degree with the x-axis where the pressure is plotted and the volume is plotted on the y-axis. Whenever the curve is shifted to the right, that is for same change in pressure, there is less volume achievement, that is because of the increased compliance as can be seen in the RDS. Whereas if we give surfactant or if the lung is very compliant, for the same change in the pressure, a good amount of volume is reached. So this curve also tells us about the compliance of the lung. So here is a case of a RDS patient where this PV loop was inclined more towards the right. That is because of the high compliance with the change in the pressure. There is very little change in the volume. But once we give the surfactant, the same curve has shifted to the left. That is the yellow curve. It has shifted to the left. Now we can see that for the same pressure, we have achieved a much larger volume. That is our aim. So it also tells us about the work breathing. The pink shows us the resistive work, which is because of the inherent resistance of the lung. And then we have uh, the one in the green shows us the elastic work. Together, this gives us this area gives us the work of breathing. And another important concept in this curve is the lower inflection point and the higher inflection point. Normally, whenever we are ventilating a patient, our aim should be to ventilate between these 2 points, that is between lower inflection point and upper inflection point. Usually, the PEEP should be set above the lower inflection point. So we can see that beyond this point, for each change in pressure, we get a good rise in the volume. And if we have set PEEP below this point, then there is hardly change, any gain in the volume per unit change in the pressure. Similarly, if we give too much high pressures, that is above upper inflection point, then again you can see that a plateau is reached. That is with increase in pressure, there is hardly change in volume. So our aim should be to ventilate between these 2 points in order to get the maximum benefit and minimal harm to the patient. So as we're talking about that, if we give high pressures, this is called as beaking. That is, with increasing pressure, there is hardly any change in the volume. And usually this is demonstrated in the ventilators as C20 by C. That is the compliance of the last 20% of the curve divided by the total compliance. It should never be more than 1. If it is more than 1 or the graph shows beaking, that means we are giving inadvertently high pressures and we need to come down on PIP. The other important thing which can be, as we discussed, which can be seen with the PV loop is atelectasis. The graph on the left shows that there is atelectasis because the PEEP is below the lower inflection point and the lungs is not opened up. Once we increase the PEEP, that is the graph towards the right, we can see that the PV loop is complete and the atelectasis is resolved. The other thing is it can also tell us whether what mode we are using or what type of breath it is. The first shows a control breath where there's an inspiration and there is expiration. Second is an assisted ventilation, as can be seen in assist control or PSV. We know that the natural breath is a negative breath, so the initial breath is a negative breath. This is followed by the assisted help from the ventilator, which is a positive breath, so it almost forms like a fish or a figure of 8. And this is how a spontaneous breath looks in the PV loop. Coming to the flow volume loop, it tells us about, so this is the inspiration is positive in a clockwise and this is the expiration. The flow is plotted on the y-axis and the volume is plotted on the x-axis. Different ventilators have different norms. There is no set criteria, so you should be knowing how flow volume loop looks on your ventilator which you are using in your NICU. So whenever there is an air leak, the expiration never touches the y-axis. It comes back to the x-axis, and this shows us that there is air leak in the circuit. Similarly, if there is air trapping, then the expiration does not touch the baseline, and this is because it shows us that there is an air trapping, which may be because of the secretions or other reasons. Also, if there is an increased airway resistance, as can be seen in BPD, it gives us a scooped out pattern, and sometimes giving a bronchodilator helps and it resolves this. Similarly, if there are secretions in the circuit or the water in the circuit, it gives a seesaw pattern. And once we do a good suctioning, it again comes back to the normal. Now, if there is a extrathoracic obstruction, for example, a small ET tube or a subglottic stenosis, this uh, flow volume loop becomes like a square. That is, this is the graph which we see in extrathoracic obstruction. That is both during inspiration and expiration, the obstruction is there. On the other hand, if there is intrathoracic obstruction, for example, aberrant vessel pressing on the trachea, then the inspiratory flow is limited and we see a serrated pattern during inspiration only. This tells us about the intrathoracic obstruction. Sometimes if there is spontaneous extubation, the flow volume loop will look like this. This is because the patient is extubated, self-extubated. Uh, Similarly, graphics also tells us about the effect of the cycling. Here we can see that the initial two breaths are the assist control, and subsequently this is the PSV. We know that PSV is a flow cycled. So here the cycling is based on the flow. You can see the narrowing of the plateaus, and there is no inspiratory lag. That is, as soon as the flow decreases, the expiration starts. So there is no inspiratory hold, which is seen in the assist control or SIMV. Similarly, we can differentiate between SIMV or assist control. In SIMV, only the number of the breaths which we have set on the SIMV, only those breaths will be supported, and it is shown in the different color formats. Similarly, in whether if you are using assist control, then all the breaths will be which the patient is generating will be supported. So basically, pulmonary graphics is like an ECG and ABG. We need to be very familiar with them. We need to know them, what all to look for, which curve to look for, and what to look for in each curve. Then it becomes very easy to understand them, and they definitely help us to fine tune. The disadvantage with the pulmonary graphics is there are no randomized control tiles which tell us that they make any difference in terms of mortality or morbidity. But theoretically, yes, they are now essential part of the modern ventilation. and they can be used to fine tune the ventilation, to fine tune our settings. Coming to the second topic is the acute deterioration on ventilator. Many times the reasons for the acute deterioration on ventilator can be picked up with the graphics itself. So the learning objects of this part of presentation is first of all to recognize and to know what is a deterioration, how to approach a patient whenever there is a deterioration, and finally we should prevent such things to happen and what is the approach. Usually deterioration happens in the form of desaturation, that is the patient was otherwise doing well, he suddenly desaturates, he develops cyanosis with or without bradycardia, there is a sudden hypotension or there is an arrest. So it is very important to follow a systematic algorithm approach in order to find the cause and in order to stabilize the patient. We should remember that we should not panic because majority of their causes are very few and majority of the causes are treatable, provided we follow a stepwise approach, and we don't need to jump to the investigation, but we should focus on the patient and his stability. Now, the causes of deterioration can be many. They can be broadly divided into either because of the ventilator, that is, the ventilator is not functioning, or the AT tube is blocked or misplaced, or the disease has worsened, or a new disease has appeared in the form of air leaks, pneumothorax, shock, IVH, PDA, or the patient has developed sepsis. Now, whenever there is an acute deterioration, we should always call for a help, which may be an other doctor or a sister. We should have an oxygen supply, a suction in place, a umbu bag or a T piece in place, and we should also have equipment like a laryngoscope and a new ET tube in place in order if we are in need of changing the ET tube. Now, whenever we have an acute deterioration, the patient will be disconnected from the ventilator and we should bag him either with umbu bag or use a T piece. Now, once we have started bagging him, there can be two things: either there is no chest movement or there is adequate chest movement. So if there is no chest movement, we have to look for the air entry. If there may be four scenarios. One thing is we are bagging, patient is not improving and there is no air entry. On the other thing, there is no air entry, but the there is a breath sound heard over the stomach, or there are breath sounds heard but they are unequal, or there is an wheeze heard. So if there is no entry, no air entry, we are not able to hear breath sounds on either side, that means the tube is blocked or displaced. If you are hearing the sound over the stomach, that means the tube has got dislodged and it is into the stomach. We need to remove and place a new tube. If there are unequal sounds or the chest looks hyperinflated on one side, then the most probable cause can be a pneumothorax or a pleural effusion. And if there's a wheeze associated, especially in babies who are chronically ventilated, it may be because of the bronchospasm secondary to BPD or to secretions. So based on the cause, we should do a thorough suctioning, or if it is a complete block because of the pulmonary hemorrhage or because of the thick copious secretion, we should change the ET. The common bedside test, which is whenever we are suspecting pneumothorax, is a transfiltration, which can be done. If a transfiltration test is positive, we can directly put a needle in second intercostal space, mid-clavicular line to get the immediate relief. Or for if there is a spasm, we can use bronchodilators to release the spasm. If there is an normal breath sound on the auscultation but patient does not improve, then we have to look for other signs. For example, one of the common causes, especially in the preterm, is ductus, that is PDA, patent ductus arteriosus. Then we have to look for a wide pulse pressure, tachycardia, murmur, or a precordial pulsations. Similarly, if the patient was otherwise active, now has become lethargic, his CRT is prolonged, it may be because of the sepsis. If there is a variable FR2 requirement, patient deteriorates whenever we touch him, do a procedure, it is or there is a difference between preductal and postductal saturation. The patient was otherwise doing well, but he suddenly deteriorated whenever we touched him. These are some of the indicators of PPHN. Or sometimes in a preterm baby, if baby was doing fine, but suddenly develops pallor, suddenly develops tonic seizure, AF is full, then these are the pointers towards the IVH. Based on the cause, we can do the appropriate management and do the stabilize the baby. On the other hand, if we are doing bag and the patient is improving with the bag, if he's doing if he's improving with the same pressures, that is, we do not have to give high pressures, that means the ventilator is not generating enough pressures because of the leak because of the defect in the circuit or because of the defect in the ventilator per se. In that case, we have to change the ventilators. Whereas if the patient is improving, but we have to give higher pressures, we have to press back, give higher pressures, then it may be because of the partial block or it may be because of the worsening lung disease. Whenever there is a faulty ventilator, it may be commonly because of the problem in the compressor, leak in the humidifier, then we have to replace the ventilator and change. Subsequently, we have to inform our biomedical engineer so that the system gets rectified and the ventilator is uh, repaired. The common mnemonics for the common cause of deterioration is dope sip, that is either the tube is displaced or tube is obstructed. There is a pneumothorax equipment failure in the, that is failure of the blender or ventilator, sepsis or shock, IVH and PDA, which are more common in preterm babies. If no fault is detected, that is we have gone through this checklist or gone through this stepwise approach, but there is no causes identified, then we should try to comfort the baby. Think of giving analgesia if baby is fighting the ventilator despite fine tuning the settings. We should try to increase the rate if the baby is having tachypnea so that to capture his rate. Or very rarely, especially in cases of PPHN, we may have to use muscle relaxant, but muscle relaxant should not be used as a routine in neonatal ventilation. So how to prevent? We should always deterioration actually is never an acute. Baby gives enough signs before he crashes, and so we should always see the trend, whether it is a blood gas saturation, which each monitor shows the trend. So we should always look at the trend, not just the one report. Always look trend of the vitals, look at the serial X-rays, serial ABG, serial X-rays, and we should have proper alarm should be set for saturation heart rate, so that, and alarm should never be muted, they should be responded. Alarm fatigue should not set in any NICU. We should always be ready for the emergency, not and keep emergency tray handy. We should always ensure that the patient equipment is at the bedside, especially in patients who are sick, who are ventilated, and we should have a dedicated team to approach and dedicated team to mobilize the things. In summary, always when deteriorations are common, but it is better to prevent them with a thorough meticulous nursing care and monitoring. Always follow algorithm approach for a quick diagnosis and stable the patients. True majority of the times the causes are very few and they're very easy to detect and treatable. For example, tube blockage, secretions, or a pneumothorax. However, non-pulmonary causes, for example, it's not important that only the lung problems can cause deterioration, the ventilation. Other non-lung causes like IVH, PDA, sepsis can be sometimes the cause. Always look at the baby, do not look at the monitor. Treat the baby first, mm, and then stabilize the baby, and do not jump to the investigation before stabilizing the baby. Thank you for your patient listening, and I will be happy to answer any questions. If there are any questions, kindly ask directly or put in the chat box.